A comparison of the health impacts of individual level and area-based Welsh Government fuel poverty schemes by Sian, Morrison-Rees and Sara, Lowe. Fuel poverty is the condition of being unable to afford to keep one's home adequately heated. In Wales, a household is considered to be in fuel poverty if it needs to spend more than 10% of its net income on all household fuel use to maintain the satisfactory level of heating. In 2018, an estimated 12% of households were living in fuel poverty in Wales. Prolonged exposure to low indoor temperatures and damp poses several health risks, notably related to the cardiovascular and respiratory system. The World Health Organization recommends a minimum indoor temperature of 18 degrees. As part of its strategy to reduce fuel poverty in Wales, the Welsh Government developed schemes to provide home energy efficiency improvements to those most likely to be in fuel poverty. The two main schemes were the demand-led or individual level scheme Warm Homes Nest, which ran from 2011 to the present, and the area-based scheme Warm Home Arbed. The first phase, which was examined in this project, took place in 2010 and 2011. The measures provided by both Nest and Arbed include insulation and heating upgrades, such as a more efficient boiler. Some received newer technologies like air source heat pumps and external wall insulation. The overall aim of the project is to use existing data to evaluate the impact on health of Welsh Government funded schemes designed to improve the energy efficiency of the homes of low-income households. The objectives for this part of the project are to identify the relevant health indicators, to make use of existing data held in the Sale Data Bank, and to investigate the relative impact of Warm Homes Nest and Arbed on the health of recipients. The Warm Homes Nest scheme provided access to anonymised data relating to individual applications to the schemes and the measures installed. This related to approximately 30,000 homes where we had details of the main applicants between 2011 and 2017. For the Arbed scheme, we were provided with a dataset from researchers at Cardiff University. They had requested and collated the intervention data from 28 registered social landlords and local authorities. This related to 4,968 homes from 2010 to 2012. All the data was anonymised and analysed in the Sale Data Bank at Swansea University. The main data sets we used were the scheme data that included the type and date of the intervention installed, primary care GP data, which included information on prescribing, symptoms and diagnoses, and the NHS Wales hospital data, which included details of admissions to hospital. Our inclusion criteria was being resident at a property receiving an intervention. We included all residents, not only the main scheme applicant, being registered with a GP with data available in Sale, having a household size of 10 or less. This was because the Nest data included a small number of households that contained unexpectedly large numbers of members. This was possibly due to inclusion of some multiple occupancy residents, for example converted houses, where it is probable that not all the residents would have received the relevant measure. On the basis of advice from the ADR Wales statistician and a sensitivity analysis, households with more than 10 members were excluded from the analysis. And lastly, having lived at the property for the minimum of the winter before and the winter after the measure was installed. To analyse the data, we did a difference in difference analysis, where we compared the changes in health events for the winter before and the winter after the measures were installed with the control group. Firstly, we looked at whether people had a health event in the first place, where we used binary logistic regression models. And secondly, for those that had a health event recorded, we looked at whether their medical history had become more or less eventful, where we used truncated Poisson regression models. For the control group for NEST, we created a group who had not yet received the intervention but who went on to receive it later. We created an intervention and control group for each year of the study. For the control group for RBED, we used all homes located in the 10% most deprived areas in Wales. This was created by the research team at Cardiff University. We analysed 3 groups. RBED 2011, as 70% of the RBED group received the intervention in 2011. In order to make a direct comparison between the 2 schemes, we analysed those receiving their NEST intervention in 2011, NEST 2011, and we also analysed all the scheme data from NEST, where 2011 to 2017 was included, all NEST. These are the sample sizes of the 3 groups we analysed. We included all ages in the analysis. The NEST recipients were significantly older than RBED, with a higher proportion over 60 years old. Previous work, however, demonstrated that the health effects of an intervention did not vary significantly with age. The outcome measures we examined were GP respiratory events, GP asthma events, prescribing for asthma and prescribing for infection. We did also intend to analyse emergency medical admissions. However, this wasn't analysed due to small numbers of emergency medical admissions. For the respiratory outcome measures, we looked at whether people had one or more health events in a winter period. For infection prescribing, our previous work suggested small but non-significant reduction. However, the data contained a high proportion of people, approximately 60% in each group, that had received 1 prescription only during the winter period. We didn't find any change in that proportion between winters and therefore theorised that the suggested impact was due to changes for those individuals requiring more than 1 prescription, in other words, repeated or more severe infections. We therefore repeated the analysis for infection prescribing with those with 2 or more prescriptions in a winter period, and that is what will be presented below. 79% of the Warm Homes NEST data and 86% of the Warm Home RBED data was linked to health data sets. Based on the limited information available about recipients, there was no evidence of bias in terms of the characteristics of the individuals for whom record linkage was possible compared with for those for whom record linkage failed. Resident information is based upon GP registrations. If a person remained registered at a GP practice despite having moved either temporarily or permanently away, it is not possible to detect this in the data, and people will be included in the analysis in error. Delayed GP registrations tend to be particularly pronounced amongst people who may not need to visit a doctor for long periods. This, combined with low levels of migration over the entire study period in both groups, means that this is likely to have had a relatively minimal impact on the analysis. Also, we cannot ascertain if the intervention was utilised to improve living conditions. For example, did lower cost of heating result in people choosing to better heat the house? The study showed that there was no impact from either scheme on whether recipients experienced a health condition in the first place. The following results are for those individuals who did experience 1 or more health events. This is a chart of the estimates of the scheme impact on the recipients who experienced 1 or more health events. It shows the estimated percentage change in each kind of event compared with any change for the controls over the same 2 winters with a 95% confidence interval. In summary, for respiratory health, we found a significant reduction in the average number of health events for the all-nest group, and the consistent pattern in reductions across schemes, whilst not always reaching statistical significance, suggests both schemes improve respiratory health. This impact appears to be greater among recipients of the demand-led scheme NEST. There was no significant effect on either scheme on the average number of GP prescriptions for asthma. This is, however, expected because most of prescribing for asthma is preventative and would likely be continued regardless of the number of acute episodes. For infection prescribing, possibly due to small numbers, none of these findings reached the level of statistical significance. However, the consistent pattern across schemes suggests a positive effect on prescribing for infection for individuals with more severe or repeated infections. We recommend further investigation into this once additional data becomes available. For our current and future work with this project, we intend to widen the follow-up time to compare health records for 2 years before and after the installation, and to report analysis relating to additional health conditions, for example mental health, which we hope to do in the near future. Thank you for listening.